Well, hi, everyone. Thanks for joining us, especially those of you who made it here in person. Our speaker today for the mental health and addictions rounds for this month is Dr. Victor Lee, and he is an Institute of Mental Health Marshall Fellow at the UBC Mood Disorders Center. And he is also a psychiatrist at the Complex Pain and Addiction Service at Vancouver General Hospital. He previously did his PhD in neuroscience here at UBC, so he's truly kind of a translational researcher. And today he's going to be presenting translational intersections and concurrent disorders in the fentanyl crisis. So please join me in welcoming Dr. Victor Lee.
Thank you. So, again, thanks everybody for coming to join the talk. Hopefully, this will be quite informative and entertaining talk for people to go through. Hope so. There you go. So, start with the land acknowledgement. I'd like to acknowledge that the land that we gather on is the traditional, ancestral, and unceded territory of the Musqueam, Squamish, and Tsleil-Waututh nations. So a couple of things that we're going to be covering through our talk today, broken down into 3 points here. First, I want to talk about what is concurrent disorders, just to make sure we're kind of all on the same page, but also specifically in BC, what does the landscape for concurrent disorders look like, and what does this addictions, substance use disorder, public health crisis that everybody's talking about actually is? And then based on that, we'll go into talk a little bit more about the types of research that we're doing in terms of the stuff that's going on at VGH, as well as the stuff that's going on at UBC, and opportunities that might arise, especially if you guys have any ideas, also the people on Zoom, for what might be additional avenues for collaboration that would be useful to address outstanding issues, of which there are still many in the concurrent disorders crisis. And so that'll be kind of the third point, and we'll talk a little bit about translational targets for both what I think might be interesting to look at and what also has been going on in the last little while as well, too, to kind of highlight. So first of all, concurrent disorders. So this is a term that basically simplifies down to the intersection between what mental health traditionally is understood as well as what substance use disorders traditionally has been understood. So if you look at this intersection, the Venn diagram, it's just that little oval in the middle there. It's actually kind of an interesting concept because if you look at the DSM, both of these things are in the DSM. So it's really just all mental health disorders. But for some reason, a lot of people in mental health like to silo out substances as its own separate thing. And traditionally, in the way that it's been dealt with, both in terms of research as well as clinical practice, the patients would actually be siloed as well. We don't tend to have a very good coverage of that intersection. You have your addictions experts and you have your mental health experts, and people don't talk to each other. So that's concurrent disorders. And more so, people are recognizing that it's important to address that intersection to be able to best treat the patient from a more holistic perspective. So to give you an example, alcohol use disorder is probably a pretty classic example of where there's a lot of intersection between straightforward alcohol addiction as well as various things that are kind of related to that. So commonly when you talk to somebody who overuses alcohol, they might be like, well, I use it to self-medicate my depression. And that's like a trope as old as time in movies. What happens after a big breakup? People get depressed. They drown their sorrows in alcohol, right? So a little bit making light of the issue, but there are certainly a lot of people out there who do medicate their depression with alcohol because in the moment it can certainly work, but oftentimes that perpetuates the depression. So now I've got this vicious cycle where people drink more, get more depressed, drink more, so on and so forth. So you run into problems there. Insomnia is also a very classic one too. What do people used to do? You drink a nightcap to fall asleep. So people will use alcohol to try to get themselves out to sleep, whereas otherwise they had no means to actually be able to fall asleep. Again, the more you drink, the worse it is to be able to get to sleep without alcohol, perpetuates the insomnia, and then you get this issue. So you can't deal with these issues in isolation. Can't deal with the depression by itself, hoping that the alcohol sorts itself out. Can't deal with the alcohol by itself, hoping that the depression magically goes away. Anxiety is also a common one. You can also imagine how anxiety and alcohol might play into each other, just like the way that it does with depression. Now, in terms of how often we see this overlap, it's actually quite common. So if you look at the stats, about 20% of the people with mental health diagnoses also have a substance use disorder. So about 1 in 5 people that you might see going through any sort of mental health system, 1 in 5 is going to have some sort of addiction problem on top of that. And if you flip around, if you just look at people who have addictions issues, about 15% of those have a comorbid mental illness of some sort. Usually that's some sort of depression, anxiety. Sometimes it could be a psychotic disorder. Sometimes it could be a trauma disorder, something like that. We also know that there's a bidirectional association and that if you have a mental illness or substance use disorder, having the other one is about 2 to 3 times more likely. So they're quite married issues. And looking at, the previous examples of how that person with alcohol use disorder might have problems, it kind of makes sense from an intuitive level. So we recognize that there's a lot of interplay between mental health and substances. It doesn't make sense to silo them. But at the same time, like I said, a lot of the research up until now, a lot of the way that the clinical work has been done up until now for patients is that it is silo. So, for example, if you wanted to go see somebody for your depression or anxiety, where do you go? You probably go to the Access Assessment Center at Vancouver General Hospital to be like, hey, I've got depression, anxiety, I want to see a psychiatrist. What do you do if you have an addictions issue? Well, you can actually go to the AAC, but most people actually recommend you go to a different one called the RAC, RAAC, which is at St. Paul's Hospital, stands for the Rapid Addictions Assessment Clinic. So we even have different like access clinics for people who are primarily substances and people who are primarily mood. And the Rapid Access Addictions Clinic definitely does no psychiatric work. It's only entirely addictions. So clinically, there's a little bit of a separation there. And then research-wise, there's also separation here. So if you look at the clinical disorder management, you look at the guidelines that exist for telling doctors what to do when you have a patient in front of you with both disorders, the conclusion is, well, first of all, there's a lot of guidelines out there. But most of them highlight that there's a need for integrative approach to treatment, primarily because there isn't a lot known about it, but we recognize that it's important. And so all struggle with this very small evidence base. And then ultimately, the reason that that's the case is up until now, a lot of the clinical trials that guide the guide that led to the guidelines being developed for mood disorders had substance use disorders as an exclusion criteria. So rather than using more of a real world sample for people who have mental health, it's more like let's purify our sample, enrich them for people who we know just have mood disorders, because it's probably a little bit less messy. Because we already know from an intuitive point of view that substances makes everything messier, harder to treat, poor prognosis, right? So then we artificially eliminate that and look at guidelines for people where they don't have those issues. But what that leaves us is that also we know that a lot of the medications that we have also don't work well in concurrent disorder medication. And we don't know what really does work because nobody's looked at it. So, for example, the classic teaching is back then in psychiatry. You have somebody who's depressed with an alcohol use disorder. What do? You tell them to quit alcohol. And then once they quit alcohol for 3 months, then you can see if they're still depressed. And if they're still depressed, we'll start you on an SSRI. So that used to be traditional, like maybe even 5, 10 years ago. More recently, it's more of a concurrent approach, attitude where it's like, well, sure, we can work on the alcohol at the same time, but we'll probably still want to start you on some sort of antidepressant or depression treatment concurrently while you're quitting the alcohol. Because it's not realistic to ask somebody who's been a long-term alcohol use disorder patient to be like, quit alcohol for 3 months completely, come see me back again. Most of the time, you'll just lose that person to follow because it's not a realistic plan to follow. Now, if we look at drug development, so this is the other aspect of things. Like we know that in psychiatry, a lot more medications are being developed for depression, for anxiety, for whatever it is, right? Lots of explosive growth in terms of psychedelics, for ketamine, which are the hot topics. But there's always stuff happening. Now, if you look at drug development in the substance use disorder space, it's not really that impressive. So we have a whole bunch of things that came out in the 1900s, and then the last real new thing was back in 2006. Now, buprenorphine in 2002 first came out as an oral formulation. It's since been in the 20, I can't remember now, after 2010 for sure, though, it got turned into a depot preparation. And that's probably the most quote unquote revolutionary thing that's happened within the substance use disorder space for medication. So a new formulation of an old medication. Likewise, naltrexone also comes as an IM depot formulation that lasts 30 days, going to be also quite impactful for clinical practice. But the key message here is that we have no new molecules. So we need to come up with new molecules, and that's where the translational stuff is going to come in. In terms of new directions that are not really FDA, a little bit more modern, a little bit more cutting edge, we've got a couple of other things, but none of these are massively practice changing. So within the opiate disorder space, we have intravenous OAT. So you've probably heard of programs where people either just get heroin from clinics or hydromorphone as a way to help manage opiate withdrawals and prevent overdose without having to resort to illicit supply. Cadian or sustained release oral morphine is a new thing that's being introduced as like equivalent to buprenorphine or methadone, but it's not really practice changing in any meaningful way. Same thing with fentanyl patches. The idea is if people are fentanyl users, you give them something that's a fentanyl patch, might be a little bit closer to what they actually are looking for, it might work better, but in practice, not really the case. In terms of the stimulant use disorder space, we got stuff like mirtazapine, bupropion, naltrexone, and high-dose stimulants as ideas that people are looking for, but the evidence is still pretty early, not really any clear signal there for anything to be like massively paradigm changing in terms of pharmacologics. So this is still a huge open area that needs a lot more work put into it. All right. So another thing that we need to do is to focus a little bit more on what we mean by concurrent disorders. So up until now, we were talking about substance use versus mental health as being these two areas that play with each other, that have an interplay with each other, that make the patient a lot more complex with a lot more factors to consider. And you have to tackle it from both angles. But it's not just both angles. We actually have a lot more angles to consider. So when you talk about more severely ill patients, we also have to consider that a lot of these patients face a lot of social adversity. Most commonly in BC, we have a housing crisis. Who gets hit by the housing crisis the worst? Probably people with mental health and other sorts of disabilities, right? And so social adversity in terms of homelessness, in terms of poverty, these are big issues. And because it concentrates people with substance use disorders, what happens is a lot of your peers in your life are all substance users. In fact, a lot of times we discharge people back to people where they're living, where every single one of their neighbors is using fentanyl or something like that. And we ask them, like, how long does it take for you to go through your day from when you wake up to your first trigger or exposure to like some reminder of substance use? And they'll be like, yeah, I wake up, I can smell fentanyl in the hallway. So it's literally from the moment they open their eyes, there are reminders of substance use. And so that's a very difficult environment to try to deal with. Pain is also a big one too. Obviously, with the opioid use disorder crisis, a lot of that started first off with the oxycodone and the Purdue story way back in the 1900s, right? But nonetheless, it's still kind of the same sort of idea where physical pain is a major driver for both mental health issues, but also substance use. And obviously, all of these four factors perpetuate into each other. So the problem becomes quite more complex than just simply just mental health and substances just by themselves. So, probably the downtown east side is one of the worst places in the world, at least in a developed nation, in terms of where this intersection of these four factors hit the hardest. So, what does this look like? Well, I found a couple striking photos, but honestly, like these are a couple years old now. If you go down to the downtown east side, this is literally just blocks and blocks. Everything looks like this. You'll find people just like lying on the streets. You're not sure if they're dead, if they're overdosed, or just like resting on the like you have no idea, and it's terrible. And these people don't have a lot of supports. So here on the left, we have a picture of a person. This is a packet of drugs. He's got a syringe here. These are some of the safe syringes that we pass out. So those are like those tiny little insulin syringes. We have a person who's overdosed, getting resuscitated, and he's here ready to get ready to use. And so this kind of speaks to the power of how bad the substance use disorders can actually get for these people. And then here, that's just, kind of a sort of tent city sort of thing. And then what's this guy doing over here? Who's living on the streets? He looks like he's probably getting something ready. I'm not sure if this is an artifact sticking out of his mouth or if that's like something like a pipe or a cigarette or something like that. But you can kind of see that very clearly these four factors intersect in a very brutal way for the people living in the downtown east side. So let's look at the stats for how bad that is. We've probably like heard ad infinitum at this point in time, the BC provincial message of there's an opiate crisis. We need to be doing a lot more. We need to be focusing on trying to save lives here because a lot of people are dying every single day, right? It works out to about one person dies every 3.5 hours. So today, up until now, since we woke up, how many hours has it been? I like guess I can't count right now. I'm going to guess something like 9 or 10 hours. So probably three people have died since the time that you woke up in BC, right? It's now the leading cause of death for everybody ages 10 to 59, greater than all the other causes added, the next five causes added together, which is quite striking. Most of the time you think of for young people, it's usually accidents and stuff like that, but now it's actually overdose. And then within the First Nations community, we can see that they get hit a lot harder. Rates of death are about 6 times higher. If you talk to First Nations patients, it's very clear. Like there's always going to be somebody in the family or somebody in the community who has died. Like you cannot find a single patient who has not been touched by this. And then within the downtown east side, yeah, rates of overdose are 12 times higher. So it's ridiculous how bad it can get when this intersection of concurrent stuff gets to that intersection. So if you look at a comparison to the rest of the world, this is actually kind of an interesting figure because it's deceptively paints us in a good light. So you can see the US is terrible at 277 deaths per 1 million. This is per year since 2020 or the latest possible. And the reason Canada is only 171 is because we dilute it with the better provinces. If you look at BC, we're over here. So we're 457 per 1 million people per deaths per year. So this is definitely like in terms of global scale, BC and Vancouver probably has it the worst in the world, but also means that we have a lot of opportunities to be able to do a lot more and have a lot more of an effect size for the patients that we deal with. So it's both in terms of highlighting the problem that we're dealing with, but also perhaps some of the opportunities that we have for being able to be so close to this area to be able to directly affect it so directly. So this is just the CPAS group in terms of the types of stuff that we're doing in terms of managing specifically the opioid disorder and that concurrent disorder intersection and how that's been impacting patients. And the CPAS group is kind of interesting because a lot of other hospitals, what they'll do is that the substance use disorder, like the substance use disorder consultation team is usually run by people who are medicine backgrounds. So people who are in general internal medicine, family medicine, that sort of thing, right? And then they will kind of focus on the substance piece and they will have a pretty good understanding in terms of concurrent disorder, concurrent factors that factor into the patient's presentation and treatment plans and so on and so forth. But psychiatrists are The CPAS group at Vancouver General Hospital is run by psychiatrists primarily with a couple of family doctors. And so our approach is a little bit more psychiatry first, substances second, rather than substances first and then other factors second. And so that's kind of where our approach is a little bit different. And we focus on that intersection a lot more between the mental health and the substance piece. And I think that we also are pretty good in terms of managing both the research and the bedside clinical impact piece as well too. So we try to do a lot more translational stuff. We're trying to build up a platform to be able to enable a lot more translational research. So a couple of things that I wanted to highlight that we're currently doing at Vancouver General Hospital. A lot of our work is focused on the opiate crisis, and so most of our work is focused on opiate use disorder. A couple of things that we're doing here are going to be the buprenorphine rapid induction protocols, as well as the sci-fi symptom inhibitor fentanyl infusion protocol, which is applicable for a number of different applications, which are quite exciting. And then there's this other thing that we're doing as well, which is kind of focused on prevention or sorry, not prevention, but contingency management strategy as delivered for digital app. But I can't talk too much more about that because I signed an NDA. So I'm not sure where everybody's understanding is in terms of managing opiate use disorder. But there's kind of the medication aspect of it, the pharmacotherapy part of it, so to speak, which traditionally has mostly just been methadone, right? Somebody's got like a heroin use disorder, you start them on methadone, that's just kind of understood that that's what you do. And the reason that that's the case is because people did some studies way back before, and they tried to compare people who were maintained on methadone versus people who were tapered off of opiates completely, and then followed them for 1 year to see what exactly happened. At least for heroin, what happens is they relapse at like 90% plus rates. And most of the relapses happen within the first 3 to 4 weeks. And so when you have an opiate disorder, it's quite severe. When you try to manage it without some sort of craving or withdrawal management on top of that, you run into issues. And so when you add on methadone, the relapse rates are much less. They're not perfect, but they're a lot better than 90% relapse rates. And so the teaching within the addiction space is that for opiate use disorder, one of the tenets is that you treat with an opiate agonist therapy. So back then it used to just be methadone. Now we have more tools. Now we have three tools total. So not a lot, but we have three at least. So you have methadone, which everybody knows is kind of like that long-acting thing. You take it, you don't get sick anymore. You have to go to the pharmacy every day. They pour it onto like a little bit of a juice and you drink it. Can be a bit stigmatizing because everybody in the pharmacist can be like, in the pharmacy sees like you're drinking the orange juice, you're probably some person with an addiction and that's your methadone, right? Since then, we've also developed that buprenorphine. So the buprenorphine is this stuff here in the bottom corner. Comes in the two formulations. One is the tablet that you dissolve in your mouth, and then one is the depot that you can inject it into the subcutaneous space in your belly. The tablet's actually kind of interesting because in Canada, we don't actually have pure buprenorphine. We only have buprenorphine that's adulterated with naloxone. Now, the reason for this is there's this theoretical you could theoretically like grind up or dissolve your buprenorphine and inject it, and then that could get you high. And then if you add naloxone into it, it'll prevent you from getting high because you've put the naloxone the same time as you put the opiate, right? And so it's an anti-abuse component to the medication. But it works as an oral formulation because if you try to eat naloxone, it does just about nothing. It's got like a 1% bioavailability. And so when you eat it, it's like it's not there, but the buprenorphine still works. And so that's the way that you can get just buprenorphine into your system. But if you try to grind it up and like snort it or inject it or whatever, or smoke it, or I guess you can't really smoke it, but if you try to take it parenterally, then it'll block its effect. But it actually doesn't have any bearing on the actual mechanism for how buprenorphine works. So that's an important thing that it's useful to understand in terms of mechanism for something I'll talk about a little bit later called precipitated withdrawal. And then finally, we have Cadian. That's that blue capsules. This is literally just regular old morphine that they then put into plastic capsules. Sorry, not plastic. They put it into a special formulation of beads such that the beads themselves cause a slow elution of the morphine out while it's transiting your GI tract. So it's a slow release morphine, but it's just regular morphine that hits your system. And so that lasts about 24 hours, was invented originally for pain. But I think BC's been the pioneer in trying to use that in terms of also as an opiate agonist therapy. Seems to be working like okay-ish in terms of like how it compares to methadone and stuff, but still a little bit early to be able to tell like how well it's going to be working. And it's not nearly as widely adopted throughout the rest of the world. So advantages and disadvantages. We can kind of break it up into full agonists and partial agonists. So full agonists are your methadone and your morphine, right? So that kind of makes sense. You got your mu-opioid receptors. If you're in withdrawal, you don't have enough tone there, so you throw on an agonist and then you feel better, you get out of withdrawal. And then the partial agonists are a little bit different in that when you throw them on, sure, it gives you a little bit more tone, but there's going to be a little bit more of a ceiling effect because you max out at that maximal receptor occupancy multiplied by the amount of effect that you get. And so you don't have the same amount of effect that you would for certainly for like a full agonist. There's a couple of benefits to this actually. One is that it's actually quite difficult to overdose on buprenorphine. It's got a ceiling effect for respiratory depression, so you get quite sleepy, but you won't stop breathing nearly as badly as you would if you overdose on methadone or something like that, right? So that's number one, it's quite good. Number two, it's a partial agonist with very high affinity. What does that mean? If you try to throw on a full agonist on top of that, for example, fentanyl or for example, heroin or something like that, it actually works as a relative blocker. Right. And so the idea is that you actually block some of the euphoria that somebody might use if they're on buprenorphine and try to use on top of that. So a couple of a dual action there that's useful in at least in theory for what buprenorphine is good for. The one major risk though is that because it's got that effect of acting as a relative blocker in an environment with lots of full agonists, you run into issues if you try to just give this to somebody who's got a lot of full agonists in their system. It'll feel like you just Narcan them and they don't like that very much at all. Not sure if you guys are familiar with what happens after somebody overdoses and you rescue them with Narcan, but the idea is that you pull off all of the full agonists from the receptors. Well, no, you don't pull off, but you replace all of it with an antagonist. And so you suddenly go from this much tone for your opiate signaling to like this much tone. And then you get really, really, really bad withdrawals that come on all of a sudden. They're also quite difficult to fix. If you ever talk to any of these people who actually get Narcan and resuscitated through it, they say it's like the worst thing ever. It's like, would rather be dead sort of thing. Just like, let me like die instead because of just how bad that precipitate withdrawal can feel. Everything's on fire. You're having explosive diarrhea. You're leaking out of your eyes and your nose, just like fluids. You're sweating. You got cotton hold sweats. You're shivering. It's just a very terrible experience to go through and can last for hours to days. And so that's the problem for that. So nobody wants to go through that. Yeah. Mhm. Yes.
So all the people that you see that are getting first responders giving them naloxone
Yes.
to recover them from respiratory depression. Do they go through that same constellation of change that you just described? Are they lying on the sidewalk, sweating, having diarrhea,
So
having
yeah.
fluid come out of many different orifices?
Yeah.
That's happening while a person's lying on the street.
It can if you overshoot. So what people have now gotten better at doing clinically is they'll try to titrate you. They won't get you fully out of like intoxication, but they'll get you to a point where you're still sleepy, but now you're breathing on sternal rub, that sort of thing, right?
Okay.
Because in the past they used to just hit you with a lot of Narcan, and that's what it looked like.
That's the old days.
That's the old days.
You've got someone who's nearly dead, they want to revive.
That's right.
So they give them too much.
Yes.
So now sadly, there's so much experience. They can actually inject a lower dose.
That's right.
Revives them from the respiratory depression,
Yes.
but protects them a little bit against these excessive withdrawal signs that you were just describing.
Exactly. Yeah.
So that's the real state now.
Yes. Yeah. Although it still depends. Yeah. You can't reliably hit that sweet spot because oftentimes what will happen is that you don't get them quite enough. And then the other reason, the main motivating factor for why EHS staff have probably started to be a little bit more nuanced in how much they deliver is because when you do deliver the Narcan, the patients usually wake up swinging. And so you need to be careful for safety. And so you don't want to give them too much. Yeah. Yeah.
And then how much formal training are first responders given in terms of all of a sudden they have to be now quasi health professionals?
Mhm.
They're giving, a treatment to a person who is nearly dying.
Yeah.
Do they get proper background treatment and all like this?
I'm not sure.
We're having right now.
Yeah.
Is it something that they're exposed to?
They would probably see this quite often just based on the number of 911 calls for overdose. I don't know about formal. I don't know. I'm not sure if there is. Yeah.
I mean, everybody, people now, of course, all the residences at UBC have Narcan available because of that sad death in the summer.
Yeah.
Is there any training that goes along with this, or just sitting on the wall like, cardiac respiratory revival thing?
I will say that probably you can do no life or limb harm if you overshoot, right? And so a lot of the Narcan kits are just basically keep giving until they're awake.
Then you induce that state that you were describing.
Right, but it's not dangerous. You can't die from it.
But it's still horrible.
Yes, that's true. Yeah. So like in terms of like there are a lot of Narcan kits as a risk reduction strategy, and actually in the States, they've rolled out a lot of that. It's actually probably caused a lot of the curbing for opiate deaths in the States at this point because now they're using Narcan kits. We haven't quite seen that here as much, probably because we've had Narcan kits for a while, and the problem's been getting worse at the same time the Narcan kits have been out there. But certainly they do make a big difference. It's just in terms of like over time, people get more and more kind of anecdotal or casual experience in terms of how to do that.
And then it exists in two forms. There's now an inhalable version.
I think so. Yeah. Yeah.
Been introduced.
Yeah.
But that's not here yet.
No, we still just use primarily IM. Yeah. And it's actually kind of interesting because you actually see that a lot of the times the resuscitations are not done by healthcare staff. They're done by peers. And so other users will resuscitate users and other like and vice versa, right? And so those people especially tend to be a little bit more on the cautious side, perhaps underdosing, because they know how bad it feels and they don't want to put their peer into precipitated withdrawal. Yeah. So anyways, the main message about the precipitated withdrawal is that it's a very real phenomenon that is very unpleasant for patients. And it's a risk for when you start buprenorphine, right? And so in the past, it used to be the case that people were getting precipitated withdrawal or other causes of withdrawal on starting buprenorphine, which actually gave it quite a bad name. And so a lot of people don't like buprenorphine because of this association that you have to go through opiate withdrawals in order to get onto it. It's no longer the case anymore and removes one of the biggest barriers, well, one of the bigger barriers for using buprenorphine for opiate agonist therapy. But just wanted to give you that context for why there might be that hesitation, why it's such a big deal to try to avoid precipitated withdrawal. So coming into here, just want to talk a little bit more about precipitated withdrawal. Just like how if you give Narcan, you displace all the full agonists and then you go into withdrawal, buprenorphine hypothetically probably works the same way. You give it, you go from a state where everything's saturated with a full agonist into a state where everything's saturated to with a partial agonist. And so your tone goes down, you go through precipitated withdrawal. But we don't really quite know how or why or the time scale for why this works, because certain things that you can do with the way that you induce people onto buprenorphine make it so that they don't go into withdrawal. Excuse me. So around 2015 was actually the time that they figured out how to do this. Before then, what people realized is that if you're already in withdrawal, and then if I give you buprenorphine, turns out it won't make the withdrawal worse. It'll only make the withdrawal better. And so they just got patients to basically wait like 12, 24 hours. Sometimes you show up to the clinic and be like, I'm ready for buprenorphine. And then you wait all day. And if you're not enough of withdrawal, you'll like, come back tomorrow and like, we'll continue there. Then you come back the next day and see if your withdrawal is bad enough to the point where you can start getting rapid doses of buprenorphine until the point where you're no longer in withdrawal. Then you know that you've reached like a pretty good dose for yourself. So that's one way. You wait for withdrawal to happen and then you kind of abort that. So that's kind of what it looks like. So you wait for the withdrawal to happen and then you give the buprenorphine and it aborts that. The problem is you still have to wait quite a long time. Like I said, sometimes it takes more than one clinical day to do that because you show up, it's not enough withdrawal, come back the second day. Most of the time, one day is good enough, but there's a problem. Oh, we are running out of battery. Do you think we have like 30 minutes left?
Yeah.
Okay, then we may not need to plug in. So since 2015, one thing that has been quite revolutionary in terms of how to do this without precipitated withdrawal is this idea called microdosing. Nowadays, we actually call it something called low dose inductions. So the principle behind low dose inductions is that if you give buprenorphine gradually, even if they have a lot of full agonists in their system, they could still be using heroin. They could still be using fentanyl. It doesn't matter. It turns out that you don't get precipitated withdrawal for reasons. And so the way that worked originally was this guy had a patient on heroin. He would give them 0.2 milligrams of buprenorphine for the first 2 days. Third day became 0.8 plus 2, then 2 plus 2.5, then 2.5 BID, then 2 to 4 BID, 4 BID, and then he got an 8 plus 4. Usual therapeutic doses for buprenorphine are around 16 milligrams. So once you're at that point, you're pretty much good. 12, and then you just go to 16, and then you're good, right? This guy got no precipitated withdrawal. He also was using heroin for the first 3 days or something like that. So it was a pioneering method to kind of demonstrate that, look, if you do this gradually, you can get to a point where you don't get precipitated withdrawal. So then the question is, this takes 9 days, which is a long time. Can you do it shorter? Right. And so it turns out you can. It was shortened down to 7 days of VGH, and then it was shortened down to 5 days. And then it got shortened down to 48 hours. And so this kind of brings into this new way of induction that we've been doing for buprenorphine starts that actually no longer even uses the sublingual formulation of buprenorphine. So up until now, you're seeing like tablets of buprenorphine given over time at slowly escalating intervals per day. But rather than doing that, you can do it through a transdermal method, right? So here, at the fastest at 48 hours, what was happening is that patients would get 0.5 milligrams of Suboxone every 3 hours, including through the night. That's for 24 hours. And then the next 24 hours, they will get 1 milligram every 3 hours for another 8 doses. And then you're good. So if you were to model the serum levels by doing that, you get this solid line. So you get these little hops of buprenorphine, and then you go up to the 1. And then by the time that you're at that serum level, you could probably get started onto like an 8 or a 16 without major issues in terms of just the precipitate withdrawal. So they come up with a way for 48 hours. You can do gradually enough, but still pretty fast to be able to get somebody onto high dose buprenorphine without precipitate withdrawal. You can mimic this with patches. So the third formulation, I didn't talk to you about buprenorphine because it's not really used for substances. It's mostly used for pain control, is the buprenorphine patch. So we talked about the oral, we talked about the injectable. There's also this patch. Now the patches, because they're for pain, are for doses that are a lot lower. So you need to use 6 of these patches. These are 20 microgram per hour patches. So it delivers 240 micrograms per, no, 480 micrograms per day, right? And so you have 6 of those on for the first 24 hours, and then another 6 of those on for a total of 12 patches for the next 24 hours. And then it basically mimics the same serum level. And so this works well. Yeah. So a bunch of case reports that were done on this. And the iteration on this is that rather than doing 24 hours and then 24 hours of patches, you can shrink it down. You can do 12 and 12. So 12 hours for the first one and then 12 hours for the second one. And then at 24 hours, you're good. Or you can break it into 8, 8, 8. And so you do 4, 4, 4 patches, and then it's still 12 patches over 24 hours. Just different ways of splitting it up. The key, though, is that you have to follow with full agonist treatment on top of that. So you have hydromorphone, which is our key, like our full agonist of choice within the hospital setting, that you give on top of the buprenorphine, so that during the 24 hours where you're asking them not to use anything, they don't just go into withdrawals because they're just not using, right? Remember, like even with the traditional method, you would wait for like 24 hours and hopefully they go into enough withdrawals so that you can get them enough buprenorphine to get out of that. We don't want that to be happening because this is a different way of doing things. Does that kind of make sense? Yeah. So then we looked at this. We did this for 75 patients over about 2 years. We did a retrospective case report, a retrospective case series, sorry, illustrating kind of all of the findings for these people. So long and short of it is generally is a pretty good success rate. About 75% of the people who got started on the protocol were able to be in successfully gone through and start onto Sublocade or Suboxone or something like that at therapeutic dose. And then withdrawals were not common, but in some cases possible precipitate withdrawal, but it's a little bit hard to say if there were any definite cases of precipitate withdrawal. So about 3 of those cases were potentials. We had a lot of missing data, though, to be able to comment on CAL score specifically, but a lot of narrative reviews and trialing were able to kind of fill in the holes for us. And then the protocol actually had quite a few deviations. When you're using this in the hospital setting, what that means is that I would order the patches for, say, like 9 a.m. and then 9 p.m. But because the hospital ward doesn't, you have nursing shortages and there's a lot of other competing patients, sometimes it'll be like 9 a.m. the next patches and then 11 p.m. for the next set of patches or something like that. So if you look at protocol deviations, which we defined as mistiming the patches by more than 3 hours or mistiming the doses of the injections by more than 1 hour, it seems like overall still okay, right? Not any major issues in terms of the outcomes there. No patients overdosed, didn't have any problems there. And then because you can just do a patch application and fire and forget, essentially, it's a lot easier to do than that every 3 hour Suboxone one where a nurse has to come in and wake up the patient through the night and stuff like that. So overall, it seems to be like a fairly effective protocol. And so this is now becoming close to standard of care at Vancouver General Hospital to be able to easily start anybody you want onto buprenorphine without precipitate withdrawals versus doing something like a standard induction versus something like a longer oral induction. So we're getting good at getting people onto buprenorphine. So the second thing that I wanted to talk to you about, which is kind of a different clinical problem that we're dealing with, has to deal with what happens when a patient comes in using exorbitant amounts of full agonist unregulated fentanyl, and they have really bad withdrawals that you can't manage in hospital. So they're maxing out the amount of hydromorphone that we use as standard orders in the hospital. They're still in really bad withdrawals. What's the next step? Right. And so this was developed as originally a means to solve that issue. For people who are already using IV fentanyl, you give them IV fentanyl in a measured way to be able to get them out of withdrawal or pain or whatever it is that you need to be dealing with at the moment. Because remember that most patients we are seeing are not coming in because of simply withdrawal. They're usually coming in with a medical issue. Say they got like an osteomyelitis, say they got like a cellulitis, say they just got in a car accident, right? So not only are you dealing with their addictions issues, you're also having to deal with a lot of the new pain that they're dealing with too. So a little bit of a more complicated issue on top. So this is kind of what it looks like. The idea is that we have fentanyl stock in the hospital. They usually use this for surgeries. You use a lot more than you would normally expect to use for a surgery. And then you give fentanyl in a systematic way such that you can reach a point where you've met their opiate withdrawals. Usually we can tell that by either the patient telling us that it's okay, or they start to get just a little bit sleepy. So that's considered the Pacero opiate sedation scale of 2 or higher. One's like fully alert, 2 is like a little bit drowsy, 3 is like quite bad, and 4 is like, tugged in. The actual orders have since evolved since it was first conceptualized, but this is the PPO for what it used to look like. Pretty small loading doses nowadays. 200 to 400 mics of fentanyl every 5 minutes. 5 minutes chosen because it's 5 minutes from IV delivery until it peaks in the CNS, presumably based on modeling, right? And so if you keep stacking it, and because it's short acting, you don't have to worry that much about accumulation, you can get a pretty good sense of where their tolerance is at. And then you use that to guide how much as needed doses they need in the hospital. We call those the PRN doses. So it's the initiation phase and the maintenance phase. And so you can get a sense of this. This is like a copy of the medication administration record for a patient in the hospital. These are like 8,000 mics of fentanyl every couple hours for how much they were needing, right? So to give you a sense of things, what was it? 2 milligrams of fentanyl is lethal in you or I. So this is 8 milligrams per dose, right? So it's quite a lot higher than you would expect. But now we're actually seeing that this is probably not that different from what we're actually seeing in the community in general. There's also a new program now that I'll just kind of go off on a tangent and talk a little bit about. There's a safer fentanyl program, which is run out of the downtown east side. The idea is that they actually give 20,000 microgram fentanyl tablets that they sell out to the patients as an alternative for them to go out to their dealer. So there's like pretty good, no, I shouldn't say pretty up there. There's a very small cohort of patients who benefit from this program and referral to this program where they will get like 20,000 mics of fentanyl to do as they please. And I recently saw one of these patients in hospital, and they'll use 1 or 2 of these tablets like per day when they do use it. So that's already like 40,000 mics of fentanyl that they're using per day. So a lot, right? We're dealing with very, very high tolerances in BC now, which is necessitating different approaches than how opioid use disorders used to be treated back in the heroin days when you couldn't get nearly this high in terms of your tolerance. So that's a new problem that we're now facing. So we did another one like retrospective case review. Again, not nearly as many patients receiving this protocol because we do reserve it for very edge cases. And so only 17 over the course of several years actually received this protocol. A bunch of them for, infections, 1 GI bleed, a couple related to car accidents. And so the point of this is that normally with a patient who has really high opiate requirements, what often happens and what actually becomes stigmatizing against these patients is that they have to leave hospital to use their own supply to feel better, right? Remember, the one thing that you want to avoid is withdrawals because withdrawals feel so bad. And so what's the one thing you can do if the hospital's not meeting your needs? You have to go outside and use your own supply, right? What that looks like from the hospital provider point of view is that we have a lot of documentation that says patient left AMA, patient left against medical advice, or patient left with self-initiated discharge, right? So that's usually the picture that gets painted within their chart when that happens, when we can't meet the opiate requirements. And it becomes stigmatizing because it's like, oh, that person will just leave anyways, like for this admission, we don't have to take good care of them or something like that. Not really to that point, but that tends to be an attitude that we need to avoid. So when you're able to meet the requirements, the intention was that we might be able to reduce the rates that they do leave the hospital and that they can stay in hospital long enough to get their medical issues treated, of which they can be quite severe. These patients are walking around sometimes with sepsis, sometimes with infections inside their bones, like osteomyelitis. And so if they're risking losing their limbs from the osteomyelitis, you need antibiotics or surgery or something to be able to deal with that, such that, they can, have proper health care. What we found is that it actually did not reduce the rates of self-initiated discharges. Patients would still be leaving one day and not coming back, but it increased the length of stay before they did that dramatically. So if you look in the 30 days, how long did I look? Was it 30 days or I can't remember now. I think it was 30 days. So if you look in the 30 days prior to the admission that they got sci-fi and you looked at how many hospital visits they had and how long they stayed at those hospital visits, it turns out the average length of stay before leaving was about 0.22 days, so a few hours, oftentimes into the emergency department, sometimes not even gotten seen by the emergency physician and they're out the door sort of thing, right? Because the withdrawals can be that bad, especially if they're dealing with pain on top of it, right? Because you need to medicate the pain and the withdrawals. But if they got sci-fi, they were able to stay on average 9 days. So 9 days, week and a half, you can do a lot of stuff with 9 days, right? You can treat the infection. You can get a course of IV antibiotics. You can step them down to oral antibiotics after they got their IV antibiotics. So lots of stuff you can do there. You can get surgeries even in there during that time, or at least get proper follow-up for community team connections and stuff like that. Didn't reduce rates of how often they were leaving by themselves, but certainly kept their hospital stays a lot longer. So I would say that overall, it does have a use case that seems to be quite good. Now, you were also able to transition people from sci-fi directly onto an opiate agonist therapy. Now, one thing I didn't talk about methadone, which is actually a substantial drawback, also to a lesser extent with Cadian, is that when methadone was first introduced, a whole bunch of people actually ended up dying from methadone overdose, right? And the reason is that methadone accumulates slowly over time. It's got a long half-life, variable between like 24 to multiple days half-life, depending on who you are. And so a little bit unpredictable in the pharmacokinetics, right? And so people can sometimes overshoot, and especially in the community setting, if you overshoot, how are you supposed to know? And then people might be at risk of harm to themselves. And so since that time, prescription guidelines around methadone became very strict. And so normally the old guidelines was you could only increase methadone by 10 milligrams every 5 days. That doesn't do very much, right? If you're aiming for a target dose of like 120 milligrams thereabouts, that's like what is that? That's like 60 days before your final dose. And what are you supposed to do during the 60 days of titration? Like, go figure it out, right? There's not really any good solution there, right? So nowadays, we're able to start at higher doses. It used to be 30 milligrams. Now it's 40 milligrams. Now it's going to be 50 milligrams. But we're seeing doses where people require 200 milligrams, right? So still going to be a long time before you get there. Sci-fi allows you to skip all of that. Sci-fi allows you to theoretically figure out how much opiate a person requires to get out of withdrawal, and then directly convert that into how much methadone they might receive. So that's actually currently a study that's being run at a Hope to Health downtown. That's by some of my colleagues that I think has done like about a dozen patients or so, and it's actually proving to be quite good. You can get somebody started on day one, 200 milligrams methadone. You have to track stuff like the QTC, and you have to be very careful around that. But it seems like it's well tolerated. So this whole thing about starting at 40 and slowly titrating up to 200 may not necessarily be the case anymore, may not be necessary anymore for the most of your patients where you can't be waiting that long, right? So the way that you do that, just kind of walk you through that. This is just, you would use the oral morphine equivalents that comes out of the pain research to try to convert the fentanyl to morphine and then from the morphine into an equivalent dose of methadone. So for the patient that we were just talking about, say that you were using like 48,000 mics of fentanyl per day, right? That would convert to about 480 milligrams of methadone, which is like wildly out of band. Nobody prescribes anywhere close to that high, right? But at the same time, if we're seeing tolerances this high, it probably makes a lot of sense for when people are still on like 220 milligrams of methadone and they're still using like a gram of fentanyl on top of that. Like, why is that? Maybe it's because the tolerances are to the point now where simply using methadone is not even like really touching the problem to the point that it needs to be, right? So because of incomplete cross tolerance, the way that it acts at the receptor, you do cut that down some amount. So this was 380 milligrams of methadone. And this is a case where this rotation was done. So you can see that over the course of a couple of weeks, they were able to rotate it slowly in increments from pure fentanyl over to mostly methadone. And the last day it was 4,000 micrograms of fentanyl on top of just the methadone, which is a far cry from 48,000. So quite a bit less. And it seemed like it worked. Unfortunately, in this case, the patient was on methadone for a little while, but in community eventually fell off. This patient, we've been, she's currently not on any opiate agonist therapy because she doesn't believe that any of them work. So that's another thing that you start running into is that people start to not have any opiate agonist therapies that work for them anymore. So this is the Hope to Health Center where people have been doing a lot of this is the study with the sci-fi bridge onto the methadone. And so when people come in with a known amount of opiate tolerance, you can start them onto methadone. And sometimes the calculations will give you something stupid like 680 milligrams of methadone, but they cap it at 200 milligrams daily for the first start and then go from there. But it's allowed to you're allowed to jumpstart the process by quite a bit by going through this process rather than going by the 10 milligrams every 3 days sort of thing. Okay, so coming back from some of the stuff that's being done at VGH over to stuff that's happening at UBC. So focus a little bit more on the mental health and substance pieces. One thing that is kind of interesting, remember we were talking about molecules and which things work well for people who have concurrent disorders and how we really don't quite know, but we do know that a lot of classic treatments don't work well for concurrent disorder populations, right? And so one thing that's also interesting is that within the opiate agonist therapy space is that it's essentially patient choice for which one of the three that they want to start. So is it methadone, Cadian, or buprenorphine? Basically, it's whatever they feel like they would want more. But really in medicine, we should have a little bit more than that, right? We should be like, well, based on evidence or clinical trials, A is superior to B is superior to C. And so we have first, second line, but really we don't have that. Everything's first line at this point in time, right? Cadeine used to be second line because the evidence was weaker, but now it got upgraded to first line. So it's just patient's choice. And we don't have a lot of selecting factors. Like I can't tell you which one works better for pain. Well, probably methadone would, but they all work okay for pain. Which one's better for like a concurrent mood disorder? Probably none of them, or we don't really know. So there's a lot of unknowns here. So we need a little bit more guiding principles in terms of differentiating which of the three might be better for different types of patient profiles. And so this was kind of an interesting thing that I came across, which is this idea that methadone itself might actually be an antidepressant. And so the idea that opiates themselves are antidepressants is not a new idea. It's been old since like hundreds of years. But it's more so that when somebody gets depression and you give them opiates, they get a little bit euphoric and therefore it's an antidepressant. But when you look at methadone specifically, it's actually a racemic mixture. So one is the one enantiomer is the one where you have more of the opiate effect. And actually, it's interesting in Germany, they mostly use that one. They don't use racemic methadone. They use that isometric. What's the word? Can't remember the word. Racemic. We use the racemic, the mixture, but they use the purified isomer. Yeah, yeah. The enantiomer. That's the one. Yeah, yeah. So the other enantiomer is actually relatively opiate inactive, right? So it doesn't do much for people with opiate use disorder, but it might work as an antidepressant, turns out. So we know that methadone is a weak SNRI, so it's a weak reuptake inhibitor for serotonin, norepinephrine. We also know it's an antagonist at the NMDA receptor. So the idea is maybe it works kind of like a ketamine for rapid antidepressant effects. So these guys did a study. These guys have a company out in Florida, and they were looking at S-methadone, which they called this REL 1017 or something, for whether it works on depression. And so it turns out like they recruited some people, 200 some people, and then they did this. Not great. Didn't separate that much from placebo if you look at just their primary outcomes. Although if you look at remission and response rates, there's a little bit of signal there. The main thing though is that you have to keep in mind that one, the placebo response is massive. So they had like a 16-point decrease on MADRS. Is this not? Yeah, MADRS. By 4 weeks. And so that's unusually high placebo response for depression populations. And then the other thing is that they only went out to 4 weeks. And 4 weeks is pretty short in terms of depression treatment. So a couple limitations here. And then the second thing that they did is they just split out the people with severe depression scores and looked at those. And within that cohort seems to separate quite a little bit more. So it looks like maybe this S-methadone stuff might be helpful for depression or whatever. But again, this is the industry sponsored trial for the medication that they're trying to bring to market. So grain of salt. But going off of this background information, the idea is if we monitor people for who would otherwise be on like opiate agonist therapy for opiate use disorder, or perhaps even just using opiates for pain, does methadone separate out from everything else in terms of mood effects? Based on this, you would expect yes. And so I wanted to do an observational study at the Translational Pain Clinic at Vancouver General, where people come to us for postoperative opiate deprescribing. Everybody's on an opiate. Some people have substance use disorders. Some people have mood disorders on top of that. Some people are there just purely for pain. And then we rotate them onto methadone. We rotate them off of methadone, and they're on buprenorphine or they're on hydromorphone. And so there's a lot of data there that's been collected over the last few years that nobody's done anything with. And there's ongoing collecting data. I want to be able to go back and look at that data to see, does methadone separate itself out from the rest of it? If it does, that'd be pretty cool. That'd be another thing to say like, look, methadone compared to the other ones might be better for mood. And so for concurrent disorder patients, maybe we should favor methadone versus just letting, like dealer's choice, so to speak. So that's a small project that's kind of an interesting thing from a translational point of view. More translational directions, I think we can focus more on the biochemistry. So understanding a lot of people here are probably more basic science background. I want to nerd out a little bit about that as well too. So NMDA receptors are kind of the hot topic right now, or have been for a number of years now, because of how much it's been implicated in both psychiatric, neurological disorders, learning behavior, just like everything, right? And so within the psychiatric space, we know that it's obviously related to learning and behavior and therefore addictions, and also related to depression, to psychosis, and also excitotoxicity and brain damage and so on and so forth. And so we've got a lot of agents that are able to act on it as blockers, which could be very helpful for us, specifically in terms of both modulating mood symptoms, but also potentially for addictions research and so on and so forth. But now also we've got a couple of things that are also positive allosteric modulators as well, that are new tools that we haven't used within this clinical space. May be useful, might be some indication for cognitive flexibility, for relearning other patterns. Hard to say, but we now have a lot of tools around the NMDA receptor, and it still remains a focus, I think, for where we might want to be taking a lot of the translational approaches for concurrent disorders. A couple of ideas here, just kind of some things that we've kind of experienced specifically around ketamine, and more argument for the NMDA receptor as a useful target here. One is that we do know that ketamine, specifically esketamine, is very useful for antidepressant, as an antidepressant treatment. Two, we also know that ketamine also reduces opiate requirements, which is very important in a world where 200 milligrams of methadone is no longer meeting people's opiate requirements, right? Rather than trying to build up tolerance, prevent overdose, we're now in a world where we're trying to bring down overdose so we can even treat it in the first place. Or sorry, bring down tolerance so we can treat it in the first place. And so the way that ketamine is able to reduce opiate requirements, we know that this is definitely true, especially in pain research, that if you give it, they need less opiates even when they're not on ketamine anymore after the fact, because it kind of reset it somewhat. You can actually also do the same thing with Narcan or naltrexone as well too. You can reset some of the opiate subpoint with that too, with very, very low doses when you don't precipitate them. But anyways, there's a lot of different ways to reset the opiate requirements. Ketamine may be one that's able to meet both of those. And then there's a lot of kind of weaker quality evidence that suggests that ketamine itself might be helpful in treating alcohol use disorder, cocaine use disorder, opiate use disorder, but the quality evidence is pretty low. That's also why we don't use ketamine for those reasons right now. And then you also have to consider that ketamine itself is also becoming an increasingly common substance of abuse. So you have to be a little bit careful about that too. Yeah. Other targets. So you can look at ketamine metabolites as well. I know that a while back there was this idea that there's some ketamine metabolites, not necessarily ketamine per se, that was responsible for being able to work on for its rapid antidepressant effects. Might have some sort of similar sort of grounding there for some of the other effects like the opiates and stuff like that. Hard to say at this point in time, but something worthwhile to look at because the metabolites are not necessarily psychoactive. And so now you take that question of can you abuse ketamine as its own substance of abuse out of the question. And then there's some other ideas that you might be able to reset some of the opiate tolerances with other different mechanisms, such as, the 2B9C peptide, or maybe looking at some other options, such as using paroxetine to also be able to affect the system that way. So using currently approved medications in off-label capacities to be able to rapidly test out things in case reports as a possible way to do some of these sorts of things. And then obviously, we have the TGR project that's at our own group right now, which is currently going with Dr. Phillips and Dr. Krause. And so that's another avenue that we're hoping to be able to get a little bit more in, start looking in the clinical space for implementation there through collaboration between UBC and VGH. And there might also be some additional peptide technologies that might be worthwhile exploring as well too through the Wang Lab. And then finally, just wanted to bring it back to this group as well too. The whole point of the matrix and cluster is translational research. And so we have ways, we're building a research platform to try to test various different types of things for substance use disorders in a public health emergency where we are at a lacking of good new ideas, right? And so if we have good new ideas, we want to hear about them so that we can work in collaboration to try to figure out what might make this most sense. Let's do some clinical trials, write some grants together, so on and so forth. So it's an invitation also for the group to be like, I got this idea, might be useful in terms of concurrent disorders research, specifically opioid use disorders. Doesn't have to be opioid use disorders, could be whatever it wants to be, could be alcohol, nicotine, stimulants. Stimulants remains like a huge area of need because we got nothing for stimulants. And so any sort of ideas, I think that this would be a very rife field for collaboration and future projects. So key takeaways. So first of all, one is that concurrent disorders still remains a major problem that we need to be continuing to deal with. A lot of research remains to be done. It's still a fairly early field. A lot of opportunities to make a big impact here. And then also in terms of the opiate use disorder space, one thing is that we know that opiate agonist therapies are necessary, but we also know that opiate agonist therapies are not sufficient, not even close to sufficient. You can start somebody onto like the perfect regimen of buprenorphine, perfect regimen of methadone, but you discharge them back to the downtown east side. It's like treating somebody with a gambling use disorder and discharging them back to a casino. You're not doing them any favors whatsoever. So you need to tackle it from multiple angles, or at least start coming up with better ideas of how to deal with that, right? And so we're good at initiating opiate agonist therapies now, I think, right? But now it's more in terms of what do you do after. And so that's like, I think we're specifically within opiate use disorder space, that's going to be a major question that needs to be solved. Okay, so that's me.
Back up 2 slides, please. Okay. Just candidly, what is the situation in the lower mainland for access to clinical facilities where you could ask whether it's just even, a case study like a lot of this work you've described is. What is the capacity to actually conduct a clinical trial with a new idea?
So so clinical trials, I think you have to get a little bit creative about because oftentimes the patients that you're going to be working with have pretty chaotic lifestyles, right? If they can't even make it to like a doctor's appointment, how do you expect them to make it to every single study visit? But I think that there are ways around that as well too, because a lot of people will also be connected up to like a sort of community teams where you might be able to bring people to them to be able to do stuff, right? And oftentimes that's often like at least in terms of the mental health care, how that will be delivered. You can do observational stuff. You can do things where you're looking at individual cases that you build up, such as what we've been doing with the protocols for sci-fi and the Butrans inductions, where it's actually quite rapid moving because it actually simplifies a lot in terms of the logistics of how to get those sorts of research, that sort of research done, right? And so I think that depending on the question at hand, RCTs is ideally gold standard, right? But there are only certain ideas that are amenable to RCTs, but we have to get creative in terms of research. And not all good research is RCTs. There's also different ways to do good research. Yeah,
You gotta start somewhere, but
that's
I
right.
guess my question was
Mhm.
not quite that deep, but I'm just wondering about the capacity.
Capacity wise, yeah.
So we have, what, estimates of 100,000 people dependent on opioids in BC or whatever.
Yes.
We know the death rate, sadly, 8,000 down in the lower east side. But how many people are available that we could be recruiting, like yourself,
Yeah.
in order to actually begin to make a difference?
Make a
So
difference.
how many clinician addiction researchers do you think do you know
Yeah.
are currently working down in BC?
Yeah. So there's still a fair good number. And the group, the BCCSU, right, that operates out of St. Paul's, and that's the other major group in the province. They have a lot of people who are doing quite a bit of research in terms of, especially a lot of the outcomes around safe supply and Canadian and so on and so forth, a lot of the initiatives in risk reduction. And they're following up some of the outcomes from years ago now. Like there's lots of years of data, and they're reporting that. And so there's a lot of good stuff coming out of that group.
That's on a harm reduction focus.
Yeah. Yeah.
You've been focusing on.
So this is a smaller group. Yeah. So our group, I think, is probably primarily CPAS plus the outpatient component at the Hope to Health Center with Hulu and Montana. And so altogether, probably like a dozen or so people. Yeah.
That's it.
We don't have a lot of people. That's the thing.
Well, at least we have 12. That's better.
Well, maybe I'm just eyeballing like a order of magnitude, so to
So
speak.
in terms of access to the resources that you need
Mhm.
to do this, I mean, is it mainly limited by manpower, womanpower?
Manpower is a big part of it. Um, I think that also manpower is part of it. Like you mentioned, like uh, points of contact for access is also limited in some ways. Um, a lot of our work happens with inpatient admitted patients, and so we see people when they get admitted to hospital. But beyond that, we don't have a lot of access on CPAS for these patients. That's where the Hope to Health Center kind of comes in to kind of supplement that, right? But even then, Hope to Health has limited capacity in terms of what they can do. So, for example, for the sci-fi bridging study onto the methadone, right? Or the sci-fi titrating study so far, that one you can probably run like maybe one patient a week. Yeah.
On a week?
Yeah. Because you do need to follow a guy for 5 days, and the clinic staff can't do more than like one, maybe two a week. Yeah. So usually it's one a week. Yeah. So need throughput.
We have a capacity problem.
I think also, even outside of research, there's a bit of a capacity problem also in terms of what's available for treatment, right? Because I think one of the major disservices that we have within our current system is that there's not enough capacity even for regular treatment that we already have. Not even just like new stuff or experimental stuff, but even standard of care stuff is lacking. So say you have somebody with an alcohol use disorder, right? And they want to quit drinking. They will phone in to see if there's a place that can detox them, right? Because otherwise the withdrawals can be sometimes dangerous. And they can be told that the wait list is going to be sometime between 1 to 3 months. So if I'm ready to quit drinking today, I have to wait 1 to 3 months before a doctor can supervise me safely to do so. The alternative is I put myself into risk, and so I get really, really sick by quitting drinking. I go to the emergency department. Sometimes that will expedite, and then maybe I'll get into detox that day. And then detox is usually the fastest pathway into treatment. So that's treatment programs that run for multiple months, right? That kind of like help to maintain abstinence, right? That is also extremely limited. So even within like evidence-based methods for um, for substance use disorders, resources are quite lacking. And I think that probably some of that might be due to scalability issues, which comes back to the drawing board of like what other things, what other ideas we haven't thought about that would be more scalable than some of the stuff that we're doing. Because psychosocial is always going to be very difficult to scale. Yeah.
Well, I mean, we just had an election. They dismantled the mental health and substance addiction control ministry.
Mhm.
It's now back in the health ministry. There's promises of all sorts of new resources.
So I hope that that will be good. I anticipate it should be good. Yeah.
But without the people, I mean, that's what I'm learning here is the people like yourself who've had to be training now for 8 years or more.
Mhm.
Just not producing enough of you.
There's also like there's a lot of people working in addictions field, but I feel like a lot of them don't do research. That's the thing. Yeah.
I mean, they have, it's like the patient obviously wants you to deal with their own personal needs.
Yeah. Part of that, I think, also is that the system is also stretched in terms of the volume of work for people who work in addiction space. And so you're already like up to your eyeballs just doing like regular clinical care. So if you want to do research on top of that, like I don't know how that's supposed to work. Yeah.
Then the other instance, of course, is burnout.
Yeah.
I mean, just witnessing somebody like, the dramatically described the withdrawal signs.
Yes.
Goes through. To witness that continuously takes its toll.
At least we don't see the withdrawals necessarily, but certainly you do see a lot of people with the homelessness and yeah, it's tough.
Medical complications that accompany.
Yeah.
Substance misuse.
Yeah.
It's a big problem.
It's a tough problem. And I think that probably some of the hesitancy or, a lot of the inertia might also be some sort of avoidance that you don't want to deal with the biggest problems that we have, right? Because they're hard to deal with. Yeah.
Yeah, because you might fail.
Yeah, exactly. Yeah.
Thank you very much for that.
Yeah.
Quite a journey.
Thanks.
Sorry, I've already mentioned before I was running from a meeting, but I see you added Dinet Lab as a potential resource for clinical trial. So I know that they do neurostimulation, and I was wondering how that might look like in the context of substance use.
Yeah.
I have seen that for smoking cessation.
That's right. Yeah. The idea is if you hit the same DLPFC, I think on the left side. Yeah, left side. It's supposed to also be anti-craving. I think the drawback is similar to what you get in depression is that when you stop RTMS, your antidepressant effects go away pretty quick. And so if you stop RTMS for the substance use, I think the craving is also going to come back. And so like it looks like in terms of like short-term stuff, has some promise. I don't know if there's other brain regions that would be meaningful to target, but certainly it's an area that I don't think a lot of people have looked at in detail yet, right? And so there's a lot of emerging research. It's quite exciting. It's one of the avenues in psychiatry that if you have, that's actually interventional, right? And so to not forget that as a resource, but I don't have any specific ideas about what that would look like yet. Probably just from a resource standpoint point of view, but like one thing that's actually kind of interesting is there's a different type of neurostim, right? Like I don't know if you've heard about in the States, they have these devices that are wearable. You put them around your ear or whatever, and then they're supposed to somehow trigger cranial nerve like retrograde signaling or something. And then that's supposed to also make withdrawals and cravings, not necessarily cravings, but withdrawals a lot less. So people who are trying to detox themselves off opioids, which is still sort of a thing, you can use this to manage withdrawals. And so we were supposed to actually get a shipment of that, but then they changed CEOs and the board of directors like we're no longer interested in collaboration with you guys or whatever. So we're not going to get those devices. But there are devices out there that have creative applications for neurostim type of stuff. Concept in substance use disorder spaces that could be reasonable. I actually tried one of them for just for fun at one of the conferences. They had like one of those booths. Can't say anything about cravings or withdrawals, but it was right before lunch and I was not hungry when they turned it on. So the hunger went away. And as soon as I turned it off, the hunger came back. So I don't know if it's like pure placebo or whatever, but it seems to do something. Yeah. Yeah. But it's quite buzzy. Like it's like a TENS unit that they stick on your ear. So you can dial that up to be like on the threshold of discomfort for sure. Yeah.
Exactly.
Oh gosh, the company who made them that we're supposed to collaborate with was Massimo, Masimo. Massimo, I forget what the actual device is called, but they've done some like trials and stuff like that where they're showing that like the cow scores over time go down when you use the device and stuff like that. Yeah. Yeah.
Does it target a particular brain region? Sorry.
It's supposed to do vagus nerve. I'm not really sure how it's supposed to get there through the ear, but yeah, I didn't look too closely into it yet. So yeah, that's the theory for how it works. But I also wonder if it may just simply be like a distraction type of thing too. I don't know. Yeah.
Three major nerves there, two of which are accessible.
There's 7 and 5 there, right?
7 and
Oh no, 5's through here.
7
7 and yeah. But they want to hit 10, so I'm not sure how it's getting there. Yeah.